Hi, ULAR 2021. I'm Dr. Rachel Tate from West Palm Beach, Florida, reporting for RoomNow.com. The Paradox of Choice is a fascinating book written by Dr. Barry Schwartz, where he argues that from an economic standpoint, eliminating customer choice can reduce consumer anxiety. Well, it appears we've kind of entered into this type of a phase with our spondyloarthritis and psoriatic arthritis mechanisms of action for our therapeutic agents. This has given our plethora of treatment options and little evidence to support individual domain dominance with multiple guidelines with varying treatment strategies. So I ask you, consider when a patient walks into your office who has multiple domains and psoriatic arthritis, the good news is that you have a myriad of treatments in which to treat this patient. However, multiple and often complex shared decision making is actually necessary to make the choice together. So how does a physician or a clinician pour through the Eiffel Tower-sized amount of research studies and actually translate that into clinical practice? So a super interesting talk at EULAR 2021 addresses this exact situation. This was titled Personalized Treatment Strategies in Psoriatic Arthritis, and the brilliant and always eloquent Dr. Laura Coates from Oxford discusses that our current evidence-based medicine predominantly links to placebo. So we have limited knowledge on which drug is best and for which patient. We have so many therapeutic options, which include TNF inhibitors, where we have the longest safety data, and we can see efficacy across domains. Ustekinumab, which is great for severe skin, can be used in inflammatory bowel disease, has infrequent injections, which may be of benefit to your patient, but with negative AS trials. IL-17 inhibitors, again, good data across all 6 domains, better than TNFs in terms of skin disease, and may be preferable for patients who have a history of demyelinating diseases, for example. But again, caution for these patients who have inflammatory bowel disease. IL-23 inhibitors, particularly good in psoriasis trials. Negative trials in AS, though, have been recorded. JAK inhibitors, a great option for patients who want an oral opportunity with evidence for support to use across all 6 domains. So we have lots of choices. That's a great problem. But what we really need in order to determine which drug for which patient, for which domain, is truly precision medicine. This is the only thing that's really going to allow us to identify subgroups, and particularly their response to different therapies. Similar to our oncology brethren, these would need to be based on pathogenesis of disease. So a small study, a Japanese study from 2018 by Miyagawa, looked at lymphocytic Th1 and Th17 phenotyping versus no phenotyping in selection of treatment options in 64 psoriatic arthritis patients who had active disease. Immunotherapy selected in the phenotyping group was based on those particular profiles, chosen either secukinumab, ustekinumab, or TNF inhibitors. So this is a small study, but it did suggest that improvement in DAS remission and ACR response scores improved with phenotyping. So this lends to the whole question of, do biomarkers actually correspond with drugs? So here at EULAR 2021, in poster POS 0409, Dr. Angioni et al. Categorized psoriatic arthritis clinical remission on a molecular level and found that CFOS and CCD50 appear to be 2 key genes in remission for psoriatic arthritis patients. More trials, such as Optimize, which will also revisit those lymphocytic T helper 1 and T helper 17 phenotyping on a larger scale, will start enrolling in the UK later this year. Necessary studies like this may actually prove to be a path forward into personalized medicine and thus decreasing the effect on us and our paradox of choice. So I'm Dr. Rachel Tate reporting for RoomNow.com from EULAR 2021, and follow me on Twitter @UpToTate.